Hi, my name is Ian Harris. I'm going to be talking to you about the ANZ Hip Fracture Registry. I'm going to be talking about how it came about, why we do it, and how the data can be used. And then I'm going to touch on where it's going in the future as well. And hopefully it'll only take about 10 or 15 minutes. So why bother with registries at all? Well, measurement of quality is necessary to drive and document improvement. And for a lot of the measures of quality that we use around hip fracture care, they're not routinely measured. So we need to set up a system whereby we decide what these quality measures are, and we have a system whereby we can record them and feed them back to people. And hip fractures are interesting because they're not a measure of any single specialty or service. They're really a measure of the continuum of care, everywhere from the ambulance to the emergency department, nursing, dietetics, occupational therapy, physiotherapy, orthopedics, geriatrics, rehabilitation. There's really quite a broad spectrum of people involved in the care. So it's a good measure of really hospital and after hospital care. So what do clinical quality registries do? Well, they measure quality, they feed it back, and then they document the subsequent improvement in quality. And is it worth it? Well, interestingly, the Australian Commission on Safety and Quality in Healthcare recently put out a report where they did an economic evaluation of clinical quality registries, and they found that the return on investment for clinical quality registries was about 2 to 1 to 7 to 1, and that's pretty good. I mean, they'll fund a road project on a return of investment of less than 2 to 1. So what has been done, and this was our plan, this little diagram here we've carried with us from the start of the registry. We said what we need to do is develop guidelines, evidence-based guidelines on hip fracture care, determine what the standards of care are, and then create a registry to measure that. So this all started in about 2012, and it took us about a year or two to make the guidelines. And what we did is we set up a process whereby these guidelines would be of sufficient quality that they would be endorsed by the NHMRC. And that's what we did. So we got an epidemiologist and a whole lot of experts, and in September 2014 we produced the guidelines. Now these were an adaptation of NICE guidelines from the UK. We got them endorsed by all these different specialties. You can see emergency medicine, rehabilitation, carers, surgeons, physicians. It's just an example. We're not going to go through each recommendation. I'm just letting you know the recommendations have been done, and this is what they look like. So we grade the recommendation, and we put it in this format. Now, the guidelines are very heavy going. They're not useful for day-to-day care and day-to-day reference. And so what we wanted to do was convert this into a standard of care. And so what we did is this is the first time that the Australian Commission on Safety and Quality in Healthcare and the New Zealand equivalent commission got together, and they both developed and endorsed these guidelines, these standards. So this is what it looks like, and this was released in September 2016, and it was released at the same time as the first annual report of the Hip Fracture Registry, which measures against these standards. So you can see there's 7 standards that we developed, and you can also see how they go through the continuum of care. So it starts with care at presentation, then pain management, ortho-geriatric model of care, timing of surgery, mobilisation and weight bearing post-operatively, minimising the risk of another fracture, so preventing secondary fractures, and transition from hospital care. And here they are. This is just a contents page out of the standards book, and you can see the 7 quality statements. And we're not going to go through each one again. I just want to let you know that this has been done, but I'll just sort of show you an example. This is what it looks like. So that the quality statement 3 will say that a patient with a hip fracture is offered treatment based on an ortho-geriatric model of care as defined in the Australian New Zealand guideline for hip fracture care. So they're basically extracted from information in the guidelines. Now, it's interesting, when I saw this, I thought, oh, I don't know about the evidence for this, but the evidence really is there. And even in Australia, we've published studies looking at hospitals with orthogeriatric models of care compared to others. And the evidence is pretty convincing that patients do a lot better. And so what that gets converted to is a quality statement with an indicator attached to it. And it's the indicator that we actually measure against. This allows something that you can measure by. So evidence of orthogeriatric or alternative physician or medical practitioner management for an admitted patient's hip fracture episode of care. So that's what the indicators and the quality statements look like. So that's the guidelines, that's the care standards, and now we have the registry, which is meant to measure all of this. So the steering committee, this changes a little bit from year to year, but rather than look at the names, if you just have a look at the column on the right, you can see that we've got representatives from many different stakeholders. And this is what the covers look like. So the first report that came out with the standards was in 2016, 2017, 2018. We're just doing the finishing touches on the 2019 report now, which will probably be released in the next month. And you can see the number of hospitals has increased each time. The current report has information on 67 hospitals, and we currently have approval for a total of 80 hospitals across both countries. Now there's 118 hospitals in both countries, 100 in Australia and 18 in New Zealand, that treat hip fractures regularly. So we're getting up around, for Australia, the 2/3 to 3/4 mark of hospitals are approved. We've now got some 11,500 or 12,000 patients, I think. And so it's a very well put together book. The report is in two halves. There is a patient level audit, which is individual patient data, and a facility level audit, which tells you about all of the hospitals. And every hospital that treats hip fractures regularly is included in that institutional or facility audit. And this is just, I think, an update of the steering committee members who are on it now. So let's have a look at some of the things. So this comes out of the facility level audit, and the facility level audit is done on every single hospital in Australia and New Zealand treating hip fractures, and we've been doing it since 2013. So we've now got data on quite a lot, and you can see what's done well and what hasn't. You can see, for example, the provision of weekend therapy for people to mobilise on weekends is increasing, and other bits are static, other things are increasing. Things are getting better. And this is what the patient level audit looks like. So the patient level audit is of the 67 hospitals, the facility level audit is of every hospital. But so this one has facilities listed on the left, but it's based on individual patient data from those facilities. So each hospital gets a three-letter code, and at the top we have, this is the last 3 years and how things have changed in the last 3 years, and this is each hospital for this year. And then there's another graph for the New Zealand hospitals and how New Zealand's changed each year, but I'm just showing you the Australian data for this one to show you what it looks like. So this one is the use of nerve blocks, and you can see PAH in Brisbane has excellent use of nerve blocks before arriving in theatre. And down here, some of the hospitals not doing so well, including some of my hospitals. There's Southern Hospital down there, Liverpool Hospital here, and St George where I work. But it just shows you kind of the distribution. Early mobilisation, this is done pretty well. And you can see year on year that hospitals are increasing in the proportion of patients that are mobilised within day 0 or day 1. Day 1 post-surgery at the latest. Bone health medication, this one varies a lot between hospitals, but I'll just skip forward a little bit. Time to surgery is one that surgeons often look at. You can see it hasn't changed much, a little bit, maybe gone up over the years. And this is where our hospital here, Liverpool, was one of the worst hospitals with about a 50-hour median or average time to surgery, 40-hour median. But we also break down the reasons, and you can see that the big reasons for delay to surgery are largely modifiable. So that's things like delay to theatre and anticoagulation issues, which really shouldn't be a reason to delay surgery these days. We have protocols in place where we don't need to do that anymore. So you can see over half of the delays are due to modifiable factors. So this is the kind of information you get out of it. So how do we use the data? Well, we've used it in our institution to get extra operating lists, but you can use it to look for weaknesses in your care, things that can be improved, to develop pathways. We've also used it to get funding for refracture prevention. And I'll show you an example. So this is our hospital. This is Liverpool Hospital, and this is what it looks like. It tells you how many records you've got, how many patients are active, average time in emergency department, length of stay, and then scroll further down and it shows you the 7 quality statements and how you measure up against each one. Which is fantastic. And also you can get live feedback from the hospital, which I'll show you in a minute, which gives you plots your change over time. So our time to theatre was not good. And if you have a look, we were the second worst, with just a little over 50% of our patients getting to theatre within 48 hours. The biggest reason was this blue reason down the bottom here, which is delay in theatre availability. And we looked at it and we thought, gee, we have a pretty good theatre system here. We have theatres every day during the week where we get the neck and femurs done the next day. So what's the problem? And when we looked at the data, it became clear very early that the problem is that we had no weekend operating. So patients that came in on a Friday were waiting till Monday, and even some patients coming in on a Thursday were waiting till Monday. And so this was blowing out our figures. So we used this to get extra theatre time, and in August 2018 they gave us a Sunday list, and we now do 1 or 2 neck and femurs every Sunday. And you can see that the proportion of patients we got done within 48 hours went from 60-odd% to April, when we opened the theatres, to be on average with New South Wales. A quarter later we were on average with Australia, and we were up between 80 and 90% by the end of the year. So you can see how looking at your data, doing something about it, and then measuring your data to record the improvement can be done. So what's the future? There's future changes that we can do in collecting the data, using the data, and documenting improvement. We're doing that now, but we can do it all better. Let's have a look. So collecting the data, eventually we hope to have direct electronic capture. Each hospital at the moment uses its own system, so you can use paper, you can use a spreadsheet and send it to us, and you can use electronic capture and have it exported. And Western Australia is one area where that happens. We're also looking at data linkage, where we're linking to the National Death Index, for example, so that we can get 30, 90-day and 365-day mortality without having to phone the patient or attempt to phone the patient. And eventually this will be embedded in the electronic medical record. How to use the data: we're expanding the live feedback, so you get more information on your dashboard and on the graphs, looking at how to disseminate this smarter, and also looking at doing research, because a lot of very efficient research designs now rely on doing randomized trials within registries. And we set up a research committee this year, and we're looking at doing our first study on nutritional supplementation in hip fractures. Hopefully that'll start next year. And again, I've shown you these differences in how they change, but this is where we fell down in our hospital at Liverpool as well. We didn't have a fracture liaison service or a public falls clinic, and so we've been able to use that as leverage to be able to set up a fracture liaison clinic, which has since been set up. So in summary, we've summarised the evidence in the guidelines. All of this is available on our website. We've set up the quality indicators and the standards of care. We now have a system whereby these can be measured and fed back, and we can document ongoing improvement. So that's where the Hip Fracture Registry is up to. That's where it's going. And as this is a recorded lecture, I'm sorry I won't be able to take questions, but hopefully there'll be people in the audience who can. Thanks very much for listening.